HIV positive and is receiving antiretroviral therapy. The first priority, or one of the priorities, would be to have that person virally suppressed, so that the person is receiving treatment, but the person's viral load is so low that the risk of transmission becomes low, and so hence the whole approach of treatment as prevention. And so from our standpoint, from the standpoint of the clinical practitioners, our priority would be to get that person virally suppressed. Any program, any good program, will have other aspects that will include not just offering ARVs, but will include all kinds of other support, psychosocial support, counseling, adherence support, and so forth. And in fact, at every visit, patients will generally have to touch base with a social worker or a counselor or a psychologist, or somebody who can then be able to identify their issues and be able to work them through with the patient. And so there is that ongoing support that's given the patient. Of course, and the question was asked earlier, what are the other factors? Because we can give as much support, we can counsel as much as we could, but in terms of human behavior and in terms of sexual practices, we oftentimes see different practices. So you counsel on one thing, and then you have, the person leaves the clinic, and you have these kinds of behaviors that would put the person or put the other person at risk for HIV. And so there's ongoing counseling, ongoing support, but again, the priority will be to have that person virally suppressed so that you can avoid new infections. In terms of that social responsibility as well, I think clinical teams work with patients so that they can have things like disclosure, so that you're not living with this disease alone, but that with your disclosure you can have support from other people around you, and that also adds in terms of person's behavior, in terms of viral suppression, adherence, and those kinds of things. The second question, in terms of, are we giving the people a voice to tell us their stories? And that has come up on more than one occasion, because people living with HIV will tell clinical practitioners and national programs that it's okay for you to say that if you are on ARVs, you will live a normal life, but you don't have HIV, you're not on ARVs, so how do you know that my life is normal? And so in fact, very often we've heard from people living with HIV that maybe we need to change the messaging, and we need to tell the story as it really is. We know for sure that HIV ARVs improve our lives, there's less morbidity, we live longer, there's improved survivability, but there are other issues that affect the person living with HIV who's receiving ARVs. But one of the things that we've done in the project with the PCU is that through the Care for Health project, we're actually collecting these stories from people living with HIV, and we're sharing those. And in fact, I've been having some discussion with Jason, who is on the CRN Plus board and the CRN Plus project, to be able to collect some of those stories from people living with HIV. As part of the data that we've gathered around the Barbados Treatall program, we've actually pulled 2 of what we call PANCAP voices. So that's a new initiative within PANCAP, where we pull stories from PANCAP members and PANCAP partners. And 2 of the voices we've pulled from the Barbados story came from people living with HIV. And what the lady said to us is that, and it goes back to the social responsibility as well, is that she was in hospital, she wasn't taking her medication, there was poor adherence, she was in hospital, and when her granddaughter came to visit her that afternoon, and she saw her granddaughter playing at her bedside, she realized that she needed to make a change. She had a responsibility not just to herself, but to her family and her friends and her grandkids. And so that's up on the website as a PANCAP voice. So we're giving space and room to people to be able to tell their stories. And in fact, Timothy just whispered to me that the Treatall page is up on the website, and you can see the stories of people living with HIV as part of PANCAP voices.
Thank you. And I just want to add to the issue of social responsibility. It was last World AIDS Day that DSG did call upon us all to ensure that we take personal responsibility for protecting ourselves. And you can counsel people, I was a counselor, and so you can spend a lot of time with them. It does not necessarily mean that people will disclose. It does not necessarily mean that even if they disclose, that persons will always be careful. And as such, it's important that every one of us take responsibility for our lives, because all of us is aware that we are living in a world with AIDS. Whether we can see someone who looks as though they have AIDS or not, we know that we are living in a world. And hopefully what this presentation would have helped us to recognize is that a person, as was said earlier, looks like you and looks like me. So we don't know who is living with HIV. Many persons are also walking around and are totally unaware that they're living with HIV. So they can't possibly disclose that they have HIV to anyone. So it means that every one of us must take responsibility for protecting ourselves. The other thing that I want to add to is the issue around the conversations that we have. And the conversations, and of course our mannerisms and the way we look when we hear certain statements, and we give ourselves away. Because what it is saying is that I didn't expect to hear that, so my facial expression says, you know, wow. So we make judgments all the time. And that impacts people who are living with HIV, because the person could have fully adjusted to the fact that he or she is living with HIV, but then one day is sitting there and a co-worker makes the most negative statements about people who are living with HIV, and they don't know that this person who is sitting right next to them is living with HIV, and how that can impact them. Because you might have thought you had a very good relationship with a co-worker, you might have thought you had, you know this co-worker, this is somebody who you didn't think would discriminate, and then you're hearing these very negative things. So the question you're asking yourself would be, how would they react to me? How would they treat me if they find out that I'm living with HIV? So it's important that we are mindful of the conversations that we have. We also have to not make assumptions about people. If somebody, for example, attends a conference that have to do with LGBT or HIV, it doesn't mean the person is HIV positive. It doesn't mean the person is lesbian, gay, bisexual, or transgender because they attend such a conference. My own experience working in the gum clinic is that they all thought I had AIDS, because why else would you be working in that clinic 20-something years ago? And when I thought that that perception had changed, I have found out recently through what somebody else is going through that that perception has still not changed. So we are not just given this information here within the CARICOM Secretariat as a means of helping you to improve your knowledge, but what do you do with the knowledge? How do you, when you get back into your departments, when you get into your homes, into your churches, how do you use this information? How do you help to bring about a change in the environment that is less discriminatory? You know, people will always make judgments. Well, what is important is that you don't act upon them. Because, you know, we can't influence how people think, but hopefully you can somehow manage to not allow what you're thinking to cause you to discriminate against someone, whether in word or in deed. Because we know it happens in thought, but not in, hopefully not in word and deed. Thanks.
Thanks again. Just two other questions. As you know, there's an ongoing debate internationally about the sex register. So I was just thinking down the road, they might be in view of the fact that you have persons that can recover, there might be a need for this register, and how we will discuss that. But more important, the mention was on the persons who, you know, if I got stuck by a needle, or it could have been, and just what Derek spoke about, you don't know if the person next to you. It also, reinforce in my mind that the organizations need to have a responsible approach, because here again, my colleague here could be ill, and I'm attending to her with liquids or fluids. I mean, I have to research this, but I don't know if we can look at placing in departments, gloves and so on, because as pointed out, that is a case, and to address your preventative approach, not that I have to run to some department to get those. We could look at having available preventatives like gloves and so on, handling. Even, I'm even thinking, even the disposal, the admin staff and how they dispose, it should be mandatory to use gloves, because based on what you just said, reinforce that. So I want a preventative wave within us, that the directorates could be given, in handling these issues. And secondly, for consideration of PANCAP, looking down the road, looking at the sex register process. Just keep in mind, somewhere down the road now, persons might be asking for a resilience register or whatever it might be called.
In terms of the register, it's important to know that, of course, once people are using their correct names, that the Ministry of Health, the various departments, the organizations, etc., that deal with people living with HIV will have them documented. What we cannot do is to use that information to restrict people in any way. As Dr. Singh did say, that as part of the program, counseling is offered, so people are given information. You explore about disclosure, but we know that not everybody necessarily discloses. If, for example, you have somebody who is knowingly passing HIV on, and somebody then says, this person has infected me, the challenge is that because our system is accusatorial, our legal system, A will have to accuse B of an action. I mean, Sandra can correct me, but if A does not accuse B, but if A accuses B, it means that A is having to say to somebody else that I am infected with HIV, isn't it? And so persons are always concerned about disclosing that kind of information, and as a result of that, there's been a lot of discussions that what is the responsibility of physicians, for example, to intervene in situations like those. And I know that the jury is still out. Some years ago, there was a discussion, I know I've gone on a little bit beyond what you said, but some years ago, there was a discussion in Parliament where to criminalize the willful transmission of HIV. And of course, there were efforts to ensure that that did not happen. There were lots of arguments that were presented based upon research, that it does not necessarily have the kind of desired impact that you're looking for. And a lot of it has to do with how do we intervene with persons. As someone who did counseling before, I mean, there were times when you had to do quite a lot of interventions as a means of helping people to understand too that when you go around having unprotected sex, it means that you can get other STIs. It means too that you can pick up other strains of the HIV because you don't know whether someone is carrying that. And therefore, sometimes on the basis of self-preservation, people are more likely to take the necessary precautions because people focus a lot on themselves. Yes?
I understand. I'm sorry. I hope I'm not being misinterpreted. What I'm looking at this register in context. Of course, in the Caribbean we have the proverbial push that graph. I'm not speaking of it in that context. Now, you mentioned about the rate. If there's such a register, and I say, well, okay, I go to the police, I'm saying John Brown, that helps, because you said it was a 72-hour window of use. So that makes it effective in utilizing the rest. So I'm speaking of it in the context of that nature. Not for me to go and see, to start and continue the Bush telegraph. That's not what I'm looking at it in that context. It's more in relation to looking at preventative and mitigating the preventative issues. So even in the context of the educational standpoint, because someone asked what was the stage between the guy looking how he was and how he is. That register would also help you cost your medication, even looking at the improvement of the type of medication and so on and so forth, if it is also social, that helps that. So that's, I'm looking at it to help, not necessary to enhance the Bush Telegraph. So please.
Right. But as part of the whole clinical management, those type of things are monitored, because of course you do have situations where people are on treatment and then there is resistance, so they may have to go to second line. But one will have to determine, is it that there is that resistance to the medication, or is it that the person is not adhering to the treatment that might be causing that resistance, but as part of the clinical management, those things are already being taken into consideration. Yeah.
I just wanted to add a bit to what you said about the absence of the criminalization of delivery transmission of HIV. So it takes us back to what you had said earlier and underscores the importance of everybody protecting themselves, because that comes up a lot in discussion, the fact that it's not a criminal offense. And I know there were discussions, but I don't know if there are plans to take the discussions further, because in many other countries it has been criminalized. But in the region here, it's criminalized.
Criminalized willfully. You do that. And we had recently a case in Suriname whereby the stepfather willfully to punish the wife, 4 children, 4 his stepchildren, girls. He infected all of them willfully. So he got, I don't know how many times more, and I think he will never get out of jail. So these are serious issues, huh? These are serious issues. And I said, boys, many rape cases are not being reported. Many rape cases, and not only girls. We have to be very careful with our boys. This is not 1945, right? So it's just 2 days ago again, and I'm thinking, your mind, the man say, oh, the girl acts it herself because she's walking in the short skirt and walking in a certain way, so it triggered me. But those poor little boys, what do they wear? What sort short skirt and so on do they wear? That these men, use them. No, you're laughing, but these are serious issues. And we laugh because it never happened to us. But the day that it happens, your father, your judge, your God, you become everything. Right? So these things are really serious issues. It's not only about girls anymore, it's now also about our own boys, the young children. Right? And even these cases do not go reported. People don't report. And then you have the cases in the villages, like in Guyana, in TNT, whereby there is a rape, and they say, okay, not going to the police, let them get married, and so on. Child is born, all these things, nothing's being reported. It goes on. And that's why Dr. Green mentioned in the first session that the percentage of infection among the younger population of girls is now increasing, which means the children. It's the children. So, that's why we're having this session. When I was asked, I found it very necessary, because many people here in the Secretariat are pastors, right? Right or wrong? You're from church. People are very serious about going to church. Other people have community obligations and so on. Please take this information back to your family, to your churches, to your community. Right? Share the information, share the knowledge. Right? Be responsible towards your family, yourself, but also your community. Only in that way we can help. And people who are infected, right? Let us try also to help them, assist them, understand them, so that they also can become become social responsible people, right? Because nobody's going around to look for sickness and so on. Okay, so together we have to bear the responsibility. Together we have to share the burden and take responsibility. And some of the things do not cost money. What it does cost is commitment and some energy from our own side. That is important, right? So, any other question or comment? Yes, please.
Dr. Springer, when you addressed the cost of the PrEP, in terms of getting buy-in from governments, are the insurance companies also being involved?
The current discussion is in relation to the assessment that we need to do in order to share this information with our national governments. In 2011, PANCAP had engaged with the insurance companies in the region. We had a regional meeting in Trinidad and Tobago to really have a discussion around the opportunity lost by insurance companies for not insuring or providing products for persons who are living with HIV. And what came out of that discussion was that the insurance companies were saying is that if what they need is the evidence, and I think that now we have that evidence, with Dr. Singh presented that evidence in terms of what the science is saying, because they have to take into consideration that, okay, if a person tests positive for HIV today, what is going to be the person's in terms of life expectation? They will also take into consideration things like hospital episodes, opportunistic infections, etc. What might be the burden to the insurance company? So I think now we have that kind of information. And last week when PANCAP had its advisory group on resource mobilization, which is headed by the Director for Resource Mobilization Technical Assistance here at CARICOM, we did have that discussion about re-engaging with the insurance companies. At that time, of course, we weren't having that discussion around the PrEP. And so these are the type of discussions that will need to take place, given that things are constantly changing, and what those issues are the ones that we're going to be placing on the table for discussion. So that did come up last week, that we need to re-engage with insurance companies.
Okay, so now I'm going to ask final, Dr. Singh. Final words.
Thank you, DSG. I just wanted to make two points, and I think it was raised about our little children and our boys. We need to really look out for the kids, and I'll give you one thing that I look for in clinic. If you see a boy child coming with anal warts, that's your red flag. So if you see a child who has warts, more than likely that child is being abused. So I just wanted to make that one point. The second point that I wanted to make was in terms of the elderly. We haven't spoken about the elderly. And in fact, I'll share with you some experiences that I have in the clinic. I had this older woman who came back from North America, having worked her entire life, got a pension, coming back home to live comfortable. And vulnerability raises its head in all kinds of different forms. Her money made her vulnerable because she got engaged with a young man because of the money, and she ended up in the clinic being HIV positive. The other point that I wanted to raise, and we've seen it very often, it may seem like a joke that you have an older person living in the community, and every now and again the boys in the neighborhood will jump the house and rape her. We've had people who've come to clinic because of things like that, who've turned out to be HIV positive. And so I think Derek says we live in a world with AIDS, but we have to be our brothers and sisters keepers, and we need to look out for things like those. So the elderly also is at risk, and when you think about vulnerability, like I said, it manifests itself in so many different ways. And person with disabilities. And in fact, I was walking with my phone reading, coming over, and I was reading that there was another robbery on the East Bank or something like that last night, 75-year-old woman. She wasn't raped, but the one in Barbie, she was raped, right? And so we have quite a few of those cases as well. So let's not forget our boys, let's not forget our children. Watch out for if you ever see any genital anal warts, that's your red flag. And keep an eye out for the elderly as well.
Mr. Cole?
Yes, I have one question that's burning on my mind. I've listened to all the discussions and the presentation as well. And my question has to do with the search for a cure, right? I have not heard anyone talk about the Caribbean's involvement in research leading to a cure for this disease. In fact, I think we've placed ourselves at the bottom of the ladder in this area, and we typically just rely on the developed countries to tell us what is the latest drug or measures and things like that. But I have not heard anything about what we are doing in terms of our own scientific research. Like, for example, if a cure was available from something that is natural and it's right in our forest, who's going to find it? Who's even going to try it out? Who's going to do the scientific research to see how effective a prospective cure might be? We're not hearing anything. As a matter of fact, I believe, this is my personal view, it might be controversial, but I do believe that a lot of the drugs that are being handed to us is basic commercial interest. I don't really believe that there's genuine interest in looking for a cure, right? And from my perspective, I think also that there are things out there that can cure the disease, but because it is so cheap and it could probably cure a wide range of diseases, pharmaceutical corporations are not going to allow it to even appear on the market. So they will discredit every little thing. And we don't hear anything in the Caribbean about these commercial interests or combating these commercial interests or doing our own research and making our own minds up about what is out there. We're just taking everything hook, line, and sinker. And that's my view on it.
Dr. Singh, final.
So that's a really complicated question to close off with. But I just want to say that if we go back to the picture that we had of the boy who had full-blown AIDS and where he is today, TB, HIV, co-infection, living a healthy and productive life and so forth, we've come a long way from since the first, in 1981 when we had those first 5 cases of PCP. And so not only patients living with HIV are living longer, they're going back to their workplaces. In fact, they're dying not of AIDS-related causes, but they're dying of other chronic diseases, so diabetes, hypertension, whatever the case might be. But to add to your question, I mean, I don't know, and Derek can help me out here in terms of how well established is that scientific research within the region that we're talking about to be able to look at herbs and those kinds of things. A simple thing like running a randomized clinical trial, we don't have the infrastructure in the region to set up a randomized clinical trial that I spoke about, some of those trials. We don't have the infrastructure. But to say that there's been really, really significant investment in looking for a cure, and some of the vaccines trial, that there've been a lot of investment in trying to get there. There's ongoing work, and in fact, I think there's a conference that's upcoming shortly that would again give updates in terms of where those trials are. What I want to say is that there's been a patient who's been cured of HIV, and we know that, right? There's been a single patient who has been cured of HIV. That's called the Berlin patient. And so the Berlin patient, he's an American person who had HIV in the very early days, ended up in Berlin, and the clinicians in Berlin did an entire bone marrow transplant. So they took his entire system out and and actually all his cells became new cells and so forth. But that's not something that you can do every day, right? You have to get the perfect match and so on and so forth, and then you have side effects and those kinds of things. It was done only once. I don't know how many of you recall a few years ago, there's a person by the name of Dr. Deborah Prasad, who is a Guyanese, but is a clinical practitioner at Johns Hopkins University, where she thought she found a cure. And in fact, at the conference, so what she did, she had a baby who came into the emergency room HIV positive, and she started the baby on treatment the same day, day one. WHO is now recommending, like with adults, that for children you start treatment as soon as possible. Prior to that, you waited on their CD4 to become, I think it is, less than 20% or something like that. That's when you start children on treatment. Now WHO is saying to start as early as possible. What Dr. Deborah Prasad did is, once that child walked into the emergency room on day one, she started the child on treatment, and she kept the child in clinic. And after about a year to 2 years, she couldn't find any HIV virus in this child. She could not. And so she went to CRY conference, and they held it up really high and said that here is a possibility of a cure, and we need to keep our eyes on this. The following two conferences after that CRY, she came back and said, sorry, the baby defaulted, the baby came back after a few years, and the baby had virus, right? And I think in terms of finding a cure, it's really very complex because of the life cycle and how quickly also the virus mutates. In terms of some of the other things, Derek, horrible things, what's in our rainforest and so forth, there isn't, I don't know what research exists. I do know that there is in the literature St. John's wort, and I don't know the details of St. John's wort, but it's not recommended. It interacts with some of our antiretroviral therapy, but that's as much as I know in terms of some of the horrible things. Yeah.
Just to say that we don't have a culture in the region of research in that particular area. As Dr. Singh said, that there have been extensive research to find a vaccine. We have also been heavily dependent upon external donor funding to support national and regional programs. And therefore, of course, if you have money at the national level now to move towards how do you sustain your program, governments will have to rationalize, and therefore the priority will have to be how do we look at prevention and how do we look at treatment for those who already have it. And so I think we will continue to depend upon the more developed countries to find a cure for HIV.
Okay, thank you very much. I think we had quite a good interactive session. Two things remain. One, to inform you, for those who were not here last week, that we are planning to have a session with staff children. We're thinking of the age group 10, 16, 17. We're thinking of mid-week during summer vacation. There is after lunch, which means dads, moms, you can go home, or I don't know, come here. We'll have a half-hour break, and they can go with you home on time to make sure that you go home on time too. That's another thing that, you don't want to keep your children here till 7, 9, and 10 o'clock in the evening. So that's one. Two, just like last session, this is our second and final. I'm hearing. For this period. Yeah, for this period, I'm hearing there's interest to have another session. Let's see how things go, right? I'm going to ask Ms. Beaton to give everybody, I hope everybody has received the number, but Dr. Singh mentioned when Mr. James and
There's a poll everywhere. Post test, right?
okay.
So we'll just put it on there.
Yeah. You can continue. Right.
Okay. And when Mr. James answered the question, she asked, do we have anything? So it means, Mr. James, you will be the first one, and the others will get numbers. So, Mr. James, could you please collect your envelope?
For answering what is tree called.
And for this, you have to thank Dr. Singh, because because she said, do we have something? Here you are.
Thank you very kindly.
So, may I ask Mr. Springer to take out a number, please?
Did they pick up?
11. Who has 11?
Okay, this is for you. Okay, thank you. Just make sure that Ms. Beaton writes your name on it so you can go and. And one more, may I ask Dr. Singh to. One more, please. Dr. Singh. 31.
If 31 is left, you can always use it.
No, then let's take another one. The person should
You're
be
31?
there.
He's 31.
Let's make sure that it's really 31. Let's make sure it's 31. Is it the same? Let's see. The same, right? You wanted to say that you were. Okay. Yes. So could you please, the list is there. You can go there and you can
Take the post test, please.
Yeah, take the post test. Okay. Good. So thank you very much, everyone, and I would say have a productive afternoon.
Thank you. Thank you.
Please take the post test.
Please do take the post test. That's how we're finalizing the session. Thank you.
Do you?